Okay, let's move to the last topic of this section. The next topic is neuroimaging for the critically ill student. Will be presented by the Associated Professor Elaine Clin. And now she is working at Department of Radiology, Hong Kong Children's Hospital. Please welcome Dr. Clin.
Thank you, Speaker. I just love this music. It's like it makes you feel like a rock star as you come up. It really wakes you up. Sawadee ka. So first of all, I want to thank Speaker for inviting us, coming to Bangkok, Thailand, which is my favorite destination. And I also want to thank the Radiological Society of Thailand and the Royal College of Radiologists of Thailand for the very kind invitation, and my gratitude to AOSOR for bringing AOSPR to be this part of this fantastic meeting, enabling myself to be here today. I'm Elaine Can. I'm a pediatric radiologist from Hong Kong Children's Hospital. My interest is in neuroradiology and interventional radiology. And it's great to be the last speaker. So we've moved up from abdomen to chest to the brain now. So this is where my hospital. It's at the old airport in Hong Kong. It's right in the middle of Kowloon. And if you have a look at this is we're here. This is the old airport runway. If you've been to Hong Kong back in the 1990s, seems so long ago, then you would be landing in the middle of Hong Kong amongst the high-rise buildings. And we were infamous for being challenged for pilots as they land. So I came from Hong Kong to here. My flight was just over 3 hours. And I do hope many of you can come to visit us in Hong Kong for the dim sum. And also recently born is this set of twins, twin pandas. They were born in August. They're extremely cute. In fact, you can watch them live on TV. There's a camera facing them 24/7 on TV. And they're really active and growing and thriving. So I was asked if this was my first meeting in Bangkok. Actually, I was at the meeting back in 2022. But if you remember, that was during COVID. So I joined as a virtual meeting. And it was very special because, again, it was an AOSOR, a conjoint session on MRI safety. And a friend of mine sent me the photo from the Bangkok perspective. And this is how you were. And it was social distancing, right? Remember how we used to sit? You don't do that anymore, but that was only 3 years ago, and it seems so long ago. Hopefully we don't have to do this again. And since then, things have changed. We've all gone back together, reconnected. This is Asian Oceanic Society of Pediatric Radiologists meeting back in 2023 in Hong Kong, and you can see we had a very beautiful group of contingent from Thailand. You see Supika right here. And it's always lovely to see friendly faces wherever you go. Right, so moving on. This is what we do in Hong Kong. In my department, we try to subspecialize. We only have, how many of us now? 6 full-time radiologists, and we subspecialized in fetal and post-mortem imaging, neuroimaging, cardiac imaging, musculoskeletal imaging, and skeletal dysplasia. IR and oncological imaging is pretty much our bread and butter. We are a tertiary referral center. We don't have an emergency room. Okay, so as we start, I want to show you what happens when infants present. So all these infants presented encephalopathic, yet the disease entities are very different, requiring very different algorithm of investigations and management. In a recent multi-institutional study of over 960,000 pediatric admissions in the US across 11 states, 10% of these pediatric admissions included a neurologic diagnosis. And furthermore, children admitted with a neurologic diagnosis had significantly longer median length of hospital stay, nearly 3 times more likely than other hospitalized children to require intensive care and had 3 times higher mortality. So I searched up Boston Children's Hospital Neurocritical Care Program, and this is the wide range of acute diseases that they have to handle. And unfortunately, the clinical symptoms of pediatric neurological emergencies can be quite nonspecific, with seizures and headaches representing the most frequent complaints. So our learning objectives in the next 20 minutes or so, I'd like to talk about our armamentarium, the tools that we use, and how imaging helps in the critically ill. And I'll focus on several conditions that include intracranial hemorrhages, toxins, infections, autoimmune, stroke, and very briefly on seizures, because that's a massive topic. So what are our tools? So we know that ultrasound can be performed at bedside. It's readily available. It can be a fairly quick tool in experienced hands, and it's good for brain, amongst who we just mentioned, the chest and abdomen. It's really good for superficial structures, and we can see vascular structures as well using Doppler. And CT is a good problem-solving tool because it's fast. It gives you cross-sectional images, and it's good in trauma and for bones, but there is a concern of radiation and whether you need contrast. And MRI is often institutional dependent, whether there's table time available for an urgent scan, and the scan time is long, and it's often that we need sedation in children who are not able to cooperate. Okay. Now let's begin with intracranial hemorrhages. Now, a range of injuries to the skull or brain may be seen in term babies following normal or assisted vaginal delivery. Now, there are various maternal and fetal factors which increase the risk of cranial trauma. So the question here is, what is the most common birth-related head injury? Right? Is it cephalohematoma, subarachnoid hemorrhage, subdural hemorrhage, skull fracture? I'm not going to ask you to put your hand up, right? Because I know you know the answer is subdural hemorrhage. Now, this is the same case that I've shown you at the beginning. This is a premature baby born at 32 weeks. CT showed not only grade 3 intraventricular hemorrhage, but also subdural hemorrhage along the interhemispheric fissure, subarachnoid hemorrhage, and there's marked brain edema. There's also a right occipital fracture, as you can see with the arrow. This is a case of simple vaginal delivery. No instrumentation was used. So this highlights the importance of clinical context, and we'll go in to talk a bit more about birth-related head trauma. So birth-related subdural hemorrhage. Now, in this study looking at birth-related head trauma, the authors look at 41 cranial birth injuries, and the most common cranial injury is subdural hematoma, followed by cephalohematoma, followed by SAH, and intraparenchymal hemorrhage. The most common location of subdural hematoma is actually along the tentorium, and then interhemispheric fissure, along the convexities and posterior fossa. And the calculated birth injury rate for each mode of delivery would be, most common is vacuum and forceps. They're by far the most common, and then less common are the others, including cesarean section. Now, this is another baby, full-term cesarean section. The baby was found apnea and seizuring in the ward. Here you can see that there's subdural at the subtentorial area, subarachnoid hemorrhages, epidural hematoma, and also there's a right parietal skull fracture. Study tells us that in birth trauma, fractures are more frequently depressed than linear, and the parietal and frontal bones are most commonly involved. Right, I know the next question you're going to ask me is, I can spot that subdural hematoma. Should I go on to date it to help my clinical staff and look really clever, right, as a radiologist? I just want to explain to you that there is a long-known pitfall about dating subdural hemorrhages. So classic teachings tells us that when you see a subdural on CT, if it's of mixed density with layering, then there must have been more than one episode of bleeding. Now, how accurate is this? This 5-month-old female unrestrained passenger in a traffic accident. On day 0, you can see that there's a focus on the hypodense subdural collection on the left side, right? There's a hypodensity on the left side. Sorry, the slides are coming out a bit funny. And then on day 4, there's an enlarged hematoma that required drainage. So mixed density is not a reliable indicator of more than one episode of injury. This study looked at serial neuroimaging in the timing of abusive head injury. Now, the figure shows that the time between the report of injury and the first appearance of a hypodense component within the subdural in 11 infants with uniformly hyperdense subdural hematoma on the first CT. For each case, there is a range of times which the hypodense component could have appeared. So these times range from a minimum of 0.3 day to a maximum of 16 days. So you can appreciate there's a wide range of time frame when the hypodense component appears. So be very careful when trying to date subdural or reconsider whether you should date subdural at all. Another pitfall, this is a 5-month-old with a history of macrocephaly. CT shows prominent subdural space with lateral ventricles, widened sylvian fissures, bilateral frontal subdural hematoma. This is not a case of trauma. This is a case of glutaric aciduria type 1 who do, for those of you who do more pediatric radiology, this is quite a typical case. And this scenario is a differential diagnosis of abusive head trauma. And with this case, I would like to move on to the next topic of metabolic and toxins. Now, there are multiple causes of neurotoxicity in children. Causes could be intrinsic from buildup of toxic metabolites due to genetic or acquired disorders or metabolic abnormalities. Extrinsic causes, such as medications and toxins, insults, illicit drugs. 2 common imaging patterns of neurotoxicity are PRES and acute toxic leukoencephalopathy. Now, each early identification and common of less uncommon and common imaging findings would facilitate early diagnosis and early treatment. Now, you can spot this now because we've been through this case before. So this is the same case of glutaric aciduria type 1. This is MRI, and on MRI there's increased T2 signal in bilateral globus pallidi and large sylvian fissures, right? You can spot it, and then there's a subdural on the right-hand side. So this is a case of glutaric aciduria type 1, not chronic changes in a case of non-accidental head injury. But these are direct differential diagnosis of each other. I won't go into the details of glutaric aciduria type 1. You can find these in the textbooks. But beware that, again, this is a differential of non-accidental head injury. So we have to look carefully at the parenchyma and the morphology of the brain. At my institution, early treatment-related toxicities in children undergoing cancer treatment are commonly related to extrinsic toxins, namely chemotherapy and immunosuppression. So what I mentioned before, PRES, posterior reversible encephalopathy syndrome, and acute toxic leukoencephalopathy are common examples. So just focus on the images. This is a 13-year-old on induction chemotherapy for acute lymphoblastic leukemia, presenting with seizure and labile hypertension. The MRI showed bilateral symmetrical parenchymal abnormalities with vasogenic edema. It is not reduced, signal is not reduced on ADC mapping. It's in keeping with PRES. You can see that there's an extraventricular drainage catheter that was inserted for monitoring of intracranial pressure. Corticosteroid and hematopoietic stem cell transplant are also common causes of PRES. This is a 15-year-old girl with acute lymphoblastic leukemia who received intrathecal methotrexate, who had acute toxic leukoencephalopathy. So diffusion-weighted images showed symmetrical restricted diffusion in bilateral centrum, semiovale, and chemotherapy agents such as methotrexate are the most common culprit, usually 2 to 4 weeks after its administration. I will not go into a lot of details because in the subsequent pediatric session, Professor Ji-Hai Kim will go through all these entities in details in her talk. Now let's move on into another clinical scenario. Now this is a term baby presented on day 0 with bacteremia, shock, respiratory failure, eventually went into status epilepticus. Plain and contrast CT done on day 0 showed marked edema, sulcal effacement, increased ependymal enhancement, and large ventricular system. It's all compatible with ventriculitis. Now, I've included a normal neonatal CT as reference so that you can see the normal gray-white matter differentiation in the neonate, which is not easy to spot already. So this is a case of early onset acute bacterial infection with group B strep. Early onset refers to infection within the first 7 days of life. Note that the ventriculitis is a common and early component of neonatal meningitis, as the choroid plexus is a common site of bacterial entry into the CNS. This is a case of a 17-day-old baby with group B strep neonatal meningitis. It just goes to show how quickly the disease progresses in the brain, resulting in atrophy, multiple infarcts, in this case, a large left subdural effusion. So the question I have for you is, neonatal leptomeningitis occurs in less than 1% of birth. Is that true? Infection of the CNS in neonates often impede cerebral maturation and result in severe neurodevelopmental delay. Is that true or false? The most common pathogen is herpes simplex virus. And mortality for infants with group B strep remains 70% for preemies weighing under 1 kg. So we'll go through one by one. I think the answers are quite obvious. So number 1, it is true. It's less than 1%, thankfully. And the second is, yes, it does impede cerebral maturation and result in severe neurodevelopmental delay. That's why we want to catch them early. The most common pathogen we already discussed is actually group B strep and E. coli. And the mortality rate for infants less than 1 kg is extremely high if they're infected with group B strep. This is another neonate born at 36 weeks, presented with fever on day 11, a case of E. coli septicemia. Here again, I've included the normal reference, and on plain CT, note that there is abnormal extraaxial hypodensity at the posterior fossa. Here, and with contrast, there's rim enhancement confirming presence of an empyema. So these are complications of infections. I want to illustrate the usefulness of using ultrasound in the NICU. This 5-month-old girl presented with late onset of GBS meningitis, 36 hours later starting antibiotics, and ultrasound showed marked leptomeningeal thickening and bilateral subdural effusion with mass effect on the underlying brain. And we did the MR on the same day, which showed bilateral subdural effusion. There's no empyema in this case, but note that there is sterile subdural effusions presenting up to half of the children presenting with meningitis within the first year of life, and approximately 2% will develop into empyemas. Note the abnormal T2 signal at the cortical gray matter and subcortical white matter of both frontal lobes. These demonstrate restricted diffusion, and this is cerebritis. Cerebritis actually follow the extension of exudate along perivascular spaces. Infarcts can occur, unfortunately, in about 30% of neonates with meningitis. So the spectrum of infectious complication in children with cancer actually is really vast, including bacterial and fungal infection, which are more common in these areas. Just beware that viral infection and reactivation in those who've received hematopoietic stem cell transplant. This is a patient with acute myeloid leukemia post-peripheral blood stem cell transplant. Can't just focus on the images. The MR shows high T2 signal at bilateral caudate heads and posterior putamen and bilateral insular, bilateral medial frontal lobes. These can be suggestive of viral encephalitis, but the radiological findings are limited. We were not able to differentiate into exactly which virus, so the confirmatory test was done with CSF PCR, and which is often quite necessary. You may have seen these horrifying images. These are cases of COVID-positive acute encephalopathy. Both these cases demonstrated acute fulminant cerebral edema with T2 hyperintense signal in thalami, globus pallidi, caudate, and brainstem, sulcus effacement, compression on the ventricles, and obliteration of cisterns and tonsillar herniation. Massive mass effect. The case 2 also showed myelitis affecting C2-3 and T8 to L1. These areas also demonstrating contrast enhancement. Right, so what about autoimmune disease? The sound of autoimmune disease often gives us a headache already before seeing the case or the images. Because why? Because the associations and risk factors of CNS autoimmunity is really heterogeneous. You can have genetic contributions, you can have environmental influences, epigenetic influences. Research tells us the sun exposure, vitamin D, gut microbiome, hormones, etc. can all be triggers, in addition to what we are more familiar with are infections, tumors, and other iatrogenic causes. So we can basically group them into primary CNS versus systemic disease. So this mind-boggling figure actually highlights some of the potential environment, genetic, and cellular interactions that may trigger the loss of immune tolerance to self-antigens and outlines opportunities of targeted therapeutic approaches. So here we can just basically group them into 4 major groups with autoimmune encephalitis, antibody-associated demyelination, paraneoplastic, and lastly, a group that is without defined antibodies. This is a 16-year-old male with acute bilateral lower limb weakness, acute renal urinary retention with sensory level at T4. And there's bilateral, symmetrical, increased T2 signal in bilateral paraterminal gyri extended to the memory bodies, mild leptomeningeal enhancement, and extensive cord involvement from C4 to 7 and most of the thoracic level with patchy enhancement. And 2 companion cases, I think you can kind of gather what I'm trying to point to. Another 10-year-old presented with lower limb weakness, contiguous T2 hyperintense signal in the central spinal cord with cord expansion and also involvement of the middle cerebellar, peduncle, and the pons. And on the right is a 16-year-old with prodromal behavioral change and change in sensorium for 2 months. And again, abnormal T2 signal symmetrically in the thalami and basal ganglia. So these are cases of ADEM, and it's usually a monophasic disorder. The peak onset is 5 to 8 years of life, and a history of systemic infection or vaccination in recent time is quite common. They affect gray matter, especially the basal ganglia is quite often, in addition to subcortical white matter, thalami, and brainstem, to a lesser extent the spinal cord. It is quite often difficult to differentiate ADEM and MS at first presentation. This is an interesting case, a 10-year-old girl with thyroid storm, sudden onset of confusion and aphasia of only a GCS of 9 out of 15. So on CT, there's subtle hypodensity in the corpus callosum. That is, of course, with a retrospective eye after we've done the MR. You look back, right, and that's more obvious. Also, on MR, there's T2 changes in the corpus callosum, notably in the splenium and in the centrum semiovale, and with restricted diffusion. And with steroid and plasma exchange, it all resolved. So this is a case of steroid-responsive encephalopathy associated with systemic autoimmune thyroiditis, also known as Hashimoto's encephalopathy. Now moving on to pediatric stroke, it's increasingly recognized because of morbidity and mortality amongst children. It is rare overall, with an incidence of 2.3 to 13 in about 100,000 children. There are a lot of classification systems, but in general, we can split them into arterial ischemic stroke and cerebral sinovenous thrombosis. And for arterial ischemic stroke, there is a range of arteriopaths, congenital heart disease, some prothrombotic conditions, sickle cell diseases, and systemic vasculitis. So this is a 14-year-old, good past health, sudden left-sided weakness, limb twitching, quite drowsy, and CT showed ischemia in the right MCA territory. So MR confirmed that there's a right MCA infarct, and we did a CT, an angiogram. This is MR TOF, and we showed that there is attenuated right MCA from M2. And we also did vessel wall imaging, which showed that there's concentric wall thickening along the right ICA at the cavernous segment, and there's enhancement of the right ICA to the M2 segment. So this is a case of focal cerebral arteriopathy of childhood. It's believed to be inflammatory, possibly para or post-infectious. The culprit is usually varicella zoster, but there could be other pathogens. There's a risk of recurrence, and up to 25% in the first year. And MRI is critical because it shows unilateral stenosis and irregularity of the distal ICA, proximal MCA, and or proximal ACA. Vessel wall imaging is very helpful and will show concentric enhancement as well, and the treatment was steroid. Unfortunately, 1 week later, he became more drowsy, and the left upper limb and left lower limb power dropped to 0. And the CT showed that there's a new right parietal infarct with significant mass effect. He went on requiring a decompressive craniectomy and EVD. And you can see that there's follow-up in MR in 1 month and 4 months, showing that unfortunately progressive brain volume loss or encephalomalacia and further attenuation of the M2 branches and increasing mural thickening of the right MCA. On Plavix, he progressed quite nicely, even though he's hemiplegic with power only 3 to 4 out of 5. He was back at school. ADL is largely independent. And this is another one of our oncology cases, patient with ALL on chemotherapy with acute onset of right-sided focal seizure, CT showing a recent hemorrhagic infarct in the left frontal lobe, and CT venogram shows filling defect with anterior segment, within the anterior segment of superior sagittal sinus, suggesting durovenous sinus thrombosis. So this is high risk in patients with ALL. Etiology is often multifactorial with L-asparaginase, a chemotherapy, and high-dose steroid. And I just want to quickly say here, a very quick point to make is this is an 8-year-old with cavernoma in the pons, as you can see on the CT. But more importantly, when you see one hematoma, you have to look for others. I just want to highlight how important susceptibility-weighted imaging is because it's very sensitive to blood products. You can see on T2 here, it looks fairly normal. But what we need is we need SWI to pick up all these tiny hemosiderin foci. This is actually a case of familial-cerebral cavernoma malformation confirmed with the CRIT1 gene. So it's important when you see one hematoma in a child, you have to look at the rest of the brain, and SWI is the key investigative tool to do that. Now, very quickly, I know I'm out of time, sorry. Seizures. Okay, seizures is defined as transient occurrence of signs and or symptoms due to abnormal or excessive synchronous neural activity in the brain. And epilepsy is defined as a recurrent unprovoked seizures, and it's one of the most common neurologic disorders in children. Now, just one example, and I'm done. So this is a 2-year-old seizure. Now, what we see here is bilateral symmetrical diffuse restricted white matter, showing restricted diffusion with subcortical white matter increase in T2 signal. Deep sulcus sign is positive, basal ganglia and thalami are preserved. This is a case of hyperammonemia. Now, certainly not the most common cause of seizure, but metabolic brain disease is certainly an entity to consider and highlights the pivotal role of early neuroimaging that will lead to prompt treatment. So this is a case of urea cycle disorder caused by a deficiency of enzymes converting ammonia to urea. Right, so in summary, we reviewed our armamentarium as radiologists. We can use ultrasound, CT, and MRI to identify specific entities. When clinical picture is clear, we want to look for the empyema, and when the underlying meningitis is already known, we can use it to localize abnormalities that would correlate with specific clinical findings, such as localizing a hematoma in head injury or an anatomical location in autoimmune disease. We can use it to characterize, such as the pattern of abnormality that helps us to narrow down to a list of differential. And it could help us recognize when findings are pathognomonic, such as in a pattern in toxins or in stroke, where we can localize where the abnormal vessel is. So with this, I'd like to thank you for your attention. Khop kun ma ka. I hope that you've enjoyed this first pediatric session.